Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of pediatric patients with cancer with Dr. Prasanna Ananth. Dr. Ananth is an associate professor of pediatrics and hematology oncology at the Yale School of Medicine. Here's Dr. Weiner.
Maybe you could just tell us a little bit about your background. Tell us how you got to where you are.
Yeah, so I've always been very interested in the illness experience and gravitated naturally from probably high school onwards towards working with children. So pediatrics was a natural fit. And then as a final year medical student, I had the opportunity to do a visiting elective at Boston Children's Hospital. And while I was there, I met my future and longtime mentor, Dr. Joanne Wolfe. And, here was a phenomenal, powerful woman who is trained as a pediatric oncologist, so a cancer specialist, as well as a pediatric palliative care doctor. She founded pretty much the first palliative care program in this entire country. And is also a researcher, and a mom of 3 kids. And having met her, I was just really inspired by the work that she did, by her demeanor, her approach, her passion for the work that she engaged in, and just the intellectual inquiry as well as the sort of practical aspects of pediatric palliative care research. So that's really sort of where I derived my inspiration.
And let me just say, having been at Dana-Farber for many years, Joanne was my colleague for many of those years, if not all of those years. And everything you said is exactly true. And on some level, she founded this whole field of pediatric palliative care. An amazing person who's now the chair of pediatrics at Mass General Hospital.
That's right. Yeah.
So you came to Yale a number of years ago, and here you both spent some time taking care of kids and also do research focused on palliative care. So let's first talk about cancer in children. Thankfully, this is not something we talk about all that often because thankfully it's not very common. Can you speak to that a little bit?
Yeah. So as you mentioned, it is very rare for a child or an adolescent to experience cancer. Probably around 16,000 children and adolescents are diagnosed with cancer every year in the United States. It's much higher across the globe, but fortunately in the United States, we have, even in rural communities, we have pretty good access to medical care for kids with cancer. So that amounts to about 1 in every 260 children who might experience cancer in a given year.
And to put that in context, if you just look at breast cancer, for example, it's far less than 10% of the number of breast cancer cases each year of all kids with cancer. So, and of course, breast cancer is just one of many cancers in adults. So across the country, access to care seems to be okay?
Well, in general, it's a little bit different from treatment of adult cancers in that we generally treat childhood cancers at major cancer centers. So we do know that in some locales, like the state of California, where there's a lot of rural areas and very limited access to large cancer centers, that there can be gaps in care. But what is sort of different about childhood cancer treatment is that it's very standardized. So we often follow protocols according to a big cooperative clinical trials group, the Children's Oncology Group. So for the most part, pretty much anywhere you go in the country, if you're seeing an oncologist for a childhood onset cancer, likely you will be offered treatment according to the latest published trial through the Children's Oncology Group, or based on a new clinical trial that they're rolling out. So
there are many kids in clinical trials.
That's right.
Yeah.
That's right. So it's nice in that there is this standardization, and a lot of times families that are newly diagnosed are sort of panicking, understandably, and trying to figure out where the best place is to go for care. And what I always tell families is that for the most part, no matter where you go in the country, there will be differences in terms of the services that you have access to, and the types of doctors, the surgeons, the radiation oncologists, et cetera. However, the treatment itself is pretty standard, and there will be very minimal to no differences regardless of where you go.
And of the cancers that occur in children, what are the most common? They're very different than in general adult cancers.
Yeah. So the most common types of cancers that we see in kids and adolescents are leukemias and lymphomas. So cancers of blood cells and of lymph nodes.
And is there a reason for that?
I don't know. I mean, we're trying to understand more and more through our clinical trials about what predisposes a child to cancer. And I think there's a growing understanding that most children with cancer, especially children who are really young who develop cancer, have probably inherited some sort of predisposition. But we're really lacking an understanding of what causes cancer in kids. And that is a real shift from the adult world, where a lot of cancers arise in people who have been longtime smokers or who, have other sort of lifestyle choices that have predisposed them. It's not the case in kids.
And in children, leukemia typically is acute leukemia. It's not a chronic leukemia. It is diagnosed somewhat abruptly. Someone has symptoms and they are diagnosed pretty quickly usually. But the outcome is very different than it is in adults. And maybe you could tell us a little bit about what the usual course is for a child with leukemia.
Yeah. So as you pointed out, usually it's sort of abrupt or acute onset. And that can come with a lot of challenges, both in terms of diagnosing and expediting treatment. And then also in terms of adjustment for families and children. We have to move very, very quickly. The likelihood of cure for the vast majority of leukemias and lymphomas is like greater than 85%. Recently, there has been a novel targeted therapy that has improved the outcomes for kids with acute leukemia, the most common type of leukemia, ALL, to a greater than 95, almost 98% likelihood of cure. And so we've really moved quickly. I mean, because if you think back to honestly, like maybe 70 years ago, that was when leukemia treatments were even being introduced in kids. And the likelihood of cure was very, very low. Now we're curing like virtually almost all children with leukemia. So, we fortunately have amazing outcomes, and we have a lot of really great treatments. That's not to say that it isn't grueling. Leukemia treatment lasts over 2 years. So as compared with a lot of cancers in adults, it's a lot of visits to the cancer clinic, a lot of hospitalizations, and especially in the first 6 months can be very, very intensive.
Yeah. And with this new targeted therapy, have you been able to peel back any of the other therapy, or is that a hope for the future?
I think that's a hope for the future. It's a little too soon to tell. This particular therapy, blinatumomab, kind of has been introduced in the setting of children with relapse leukemia, and only recently in a trial in the last couple of years was introduced earlier on in cancer treatment. And it was the subject of a New England Journal paper in December, and a lot of media coverage, because the outcomes in this trial that's still ongoing were so favorable towards children who had received blinatumomab up front that they had to close the trial early.
Wow.
So it's kind of amazing, and I think the hope would be to try to reduce some of the toxic chemotherapies, because other chemo medications unfortunately can't differentiate between healthy cells and cancer cells. We have very few targeted therapies that are shown to be effective in pediatric cancers, and so now that we know this, the idea would be to try to remove or minimize some of those more sort of toxic chemotherapies that have long-term side effects.
And apart from leukemias and lymphomas, the other cancers in kids, it strikes me that cancers that involve the brain are pretty common.
They're not very common. What's unfortunate about a lot of brain tumors in children is that they are often not curable.
Oh, okay.
And so that's why we
hear
about them a lot. Yeah. And the same goes, unfortunately, for solid tumors. Sometimes they can behave more aggressively, especially in adolescents and young adults. But fortunately, brain tumors and solid tumors outside of the brain are very, very rare.
And is that just because everything apart from leukemia and lymphoma is rare?
I think so.
there's no really, so there's leukemia and lymphoma, and they're really, that's 1 and 2, and then there isn't really 3. Everything else is like 10.
That's right.
Okay, got it. I know that the treatment of children who have various types of brain tumors can be quite challenging.
That's right. Yeah.
And, the other thing that I think that people have become more and more aware of over the last decade or more is that there can be long-term consequences of this therapy. And for that matter, people can get second cancers both from the therapy and perhaps because they have some predisposition.
That's right. I mean, the long-term consequences that we worry about the most are infertility, unfortunately. So for boys and men, low sperm count; for girls and young women, premature ovarian insufficiency. So, unfortunately, early sort of failure of the ovaries to function. Other things, it depends a little bit on what sorts of treatments you've received. So we worry about radiation-related growth challenges, bone health in cancers that we treat with a lot of steroids. A lot of those side effects are manageable with lifestyle changes, with medications, and with close follow-up. The risk of a second cancer related to chemotherapy is pretty low. We estimate probably less than 1% of children will have that, but that's why it's just so critically important, even after a child is done with treatment, to continue to follow up really closely with their doctors and their medical team.
Well, that's really helpful. I'm certainly getting educated. I think we're going to take a 1-minute break, and then we'll be back and proceed with the second half of the show.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where the lung cancer screening program provides screening to those at risk for lung cancer and individualized state-of-the-art evaluation of lung nodules. To learn more, visit smilowcancerhospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner with Yale Cancer Answers, and I'm back with our guest, Dr. Prasanna Ananth, who is a pediatric hematologist oncologist. We've been talking about pediatric cancer. We're going to talk just a little bit more about that, and then we're going to get into some of her research. I just wanted to ask you about pediatric cancer survivorship programs and what has become the standard these days, and finally, how you think about the transition to adulthood when people who have been seeing their pediatrician for a long, long time are 26 years old and still going to the children's hospital.
Yeah, so it's interesting. Survivorship care has really evolved. It is conceived of as very interdisciplinary. So most survivorship clinics are staffed by physicians, nurse practitioners, dietitians, psychologists, endocrinologists, cardiologists. I think there's a general consensus in the field that survivorship requires all of this interdisciplinary input and that the effects of childhood cancer can really last. So one of the things that I find a lot of folks who take care of adults are really surprised by is that we take care of children anywhere from birth all the way until they fall off their parents' health insurance. So we sometimes take care of adults. In fact, I had on my list a patient who is a childhood cancer survivor who was 30 years old. And I can't say that I feel entirely comfortable taking care of 30-year-olds, because there's a lot of other chronic health problems that I don't have the skills to necessarily manage. However, we really rely heavily upon our colleagues in the adult world. And for most survivors, they continue to come back at least to the survivorship clinic at least once a year for many years after cancer therapy. So it depends a little bit on what type of cancer you've had. But for most children with cancer, they come back at least in the first several years very frequently to the oncology clinic. And we do labs, we do an exam, and carefully monitor for recurrence of that cancer and for any of the side effects and counsel around late effects as well. Usually about 2 years after they've completed therapy, we will also refer them to our dedicated survivorship clinic for some added counseling and guidance around specific late effects to be aware of. And then about 5 years out, we can often start to see patients once a year in our clinic, and try to transition, especially for those adolescents and young adults, people that are at college or working, et cetera, who may have some difficulty coming to appointments regularly. We try to transition some of that care to primary care providers. And what I will say is that different primary care providers have differing levels of comfort with that. So some feel perfectly fine with, receiving the guidelines and managing the sort of long-term care, and others aren't as familiar with that. And that's very understandable. And so that's why our survivorship clinic exists, to be able to help support those primary care doctors in that multidisciplinary way.
Well, and as you know, primary care doctors are under a great deal of stress these days. They have 15 minutes to, see a patient, do ever so much. And I think over time, it's probably likely that they'll be less and less comfortable in this arena.
That's right.
But we'll see. As we segue into your research, I just want to ask one other question that's more general, which is about the families and what this is like for a family. I mean, I can only imagine as a parent what it would be like to have my child diagnosed with any serious illness, and in particular, cancer.
Well, it's, as you stated, it's unimaginably difficult for families. We know that cancer treatment disrupts family financial stability. Sometimes families experience food and housing instability. Many families can't work. The other children in the household will be undoubtedly affected, and so it is a whole family disruption.
And
And
when you talk to someone who had a sibling with cancer as an adult, it I mean, I've always been struck that it's so much part of their childhood is their sibling who had the cancer, no matter what happened with that sibling.
right. I mean, it's a whole family experience. And in part, I think for a lot of us who work in this world, this is what is both most challenging about this work and the most inspiring. I mean, I went into this field primarily because it was such a beautiful opportunity to be able to shepherd families through their treatment and to sit with them in their grief, and really be a part of an extremely difficult experience for many families. And that longitudinal relationship is really, really important and very fulfilling.
So the good news is most children with cancer survive, and the majority of those survive well and go on and lead very full lives. The still bad news is that some of them don't. It's a small proportion, but they exist. And your research has focused on how we care for those patients and families, those children and families, where cure is no longer possible. Tell us about that, if you would.
As I mentioned earlier, that I was really inspired largely by a mentor, and then, of course, clinical experiences. So when I was in training for pediatric hematology and oncology, I had a number of experiences of children with advanced or incurable cancer who had really difficult and contentious last weeks and months of life. So there was disagreement between the care team and the family, or between the patient and the family. And those experiences kept occurring. And it really made me think about what good end of life care looks like, what good advanced cancer care looks like. And we are talking about a very small proportion of patients. 15 to 20% of kids with cancer will not be cured. And we also now have, as I mentioned earlier, a lot of targeted therapies, a lot of novel treatments that help these children live for a very long time with a high quality of life, or a reasonable quality of life. But I really focused my research in this area of where are the gaps in the provision of care for these children with advanced cancer? Where can we do better?
And are the problems at the end of life more prominent in older children, where the patient, him or herself, is trying to take more control?
I wouldn't say that it's more prominent in older children, but I do think that the problems and the challenges are different. As adolescents and young adults increase their sense of agency and become more independent, there is another layer to decision making and shared decision making. So I do think it adds some complexity. And there are a lot of amazing investigators who are focusing their work on trying to improve advanced cancer care for adolescents and young adults. I've mostly focused my research on younger children in order to sort of carve out a niche for myself. That being said, a lot of what we've learned in our research applies to older adolescents and young adults.
And so one could imagine that you could make that end of life care easier by preparing people more. On the other hand, when someone is newly diagnosed, talking about not doing well is not exactly what they want to hear. So there's a limitation there, I would imagine.
Yeah, I mean, a lot of these conversations are a process, right? So it is very rare that we would tell someone at the initial diagnosis that their cancer is not curable, with a few exceptions. There are some brain tumors, for example, that are universally, unfortunately, not curable. And so we can extend life, but we can't necessarily cure. And so I really value honesty and truth telling in my communication. And that approach has really been bolstered by all of the sort of experiential learning, and learning from masters in palliative care. Honestly, I am not a clinical palliative care practitioner. That being said, there's a lot that we can learn as clinicians who take care of children with serious illness. We can learn a ton from the ways in which pediatric palliative care clinicians communicate.
But you are very much the one who's walking that journey with the patient and family.
That's right.
And introducing ideas about maybe cure isn't possible when that comes up. I mean, I often, and I have, of course, a very different experience as an adult cancer doctor, but I generally find that over time, as you go through an illness with a patient, that as a doctor and as a patient, you're often in sync. And that's the ideal situation, of course.
Mm-hmm. Yeah. I mean, I think that the research shows that pediatric oncologists are variable in their ability to kind of walk that journey and be honest. It can be really challenging, and it's sort of interesting being in sort of both worlds, like being a pediatric palliative care researcher as well as a pediatric oncologist. I know that it's really difficult to have honest conversations about the curability or lack of curability of a particular cancer. And I know that a lot of my peers in pediatric oncology struggle with that tension. At the same time, we also know that preparation is better, honesty is better, and being very, very forthright about prognosis helps families prepare, helps families grieve, and helps them long term in their bereavement.
And have you or others studied interventions for the pediatric oncologists as a way of helping to improve end-of-life care for children and families?
So my research is not intervention focused, but there are a number of people who are very interested in trying to intervene on the style of communication. So communication research is a huge and impactful area of research in our world.
Dr. Prasanna Ananth is an associate professor of pediatrics and hematology oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.